But thank you very much for inviting me on a beautiful Rome day. Serena has always promised me that the weather in Rome is good, and every time I've been, it's raining. But this morning it was raining in Oxford and beautifully sunny in Rome. So finally I believe her. So as Serena said, we started investigating maternal deaths in the UK in 1952, at which point we had 90 deaths per 100,000 women giving birth. We've now reduced that to about 10 per 100,000 women giving birth, but we're not really succeeding as yet in reducing things very much below that. The pattern of maternal deaths has changed completely in the UK, as it, I'm sure, has here in Italy, whereas most women were dying from pregnancy-related causes such as preeclampsia and hemorrhage in 1952. Now, most women are dying from other causes. And we know that our population has changed quite dramatically. So we know our population are more complicated. We have more obese women, older women giving birth, different, less healthy behaviours, more women with previous complications, and particularly more women with pre-existing health problems, which is clearly of direct relevance when we're talking about perinatal mental health. When we look at the causes of maternal death in the UK, the majority are from medical or mental health related causes rather than from those direct pregnancy causes. But actually, if you look at the number of deaths, and these are women who died during pregnancy or up to 6 weeks after pregnancy, the World Health Organization definition of a maternal death, there aren't very many deaths from suicide. But actually, if we look later, that's when women are dying from suicide. However, if you do look at the women who are dying from all causes in that during pregnancy and up to 6 weeks after the end of pregnancy, almost a quarter of them have pre-existing mental health problems or other psychiatric disorders. And we know very much that the women who die are much more vulnerable and have many social as well as medical and mental health complications. When we look at late maternal deaths in the UK, so these are the women that die between 6 weeks and a year after the end of pregnancy, almost more than a quarter die from mental health related causes, and that's the green and red sections on the bottom right. We're making no impact on our rate of late maternal deaths, and this is partly due to the fact that 1 in 6 women die by suicide, and despite becoming more alert to suicide as a cause of maternal death in the early 2000s, we have not yet succeeded in reducing the rate of death by suicide. We have now expanded our confidential inquiries in the UK, so we investigate not only the care of women who die, but we also, on a topic basis, investigate the care of women who survive. So the messages I'm just going to talk to you about now come not only from investigating the care of women who've died, but also from investigating the care of women who've had severe psychosis after pregnancy. So women who've had psychosis and survived, as well as those women who've died by suicide. When we look at the women who die in the UK overall, in the 3-year period of the last report, which was published at the end of last year, nearly 5 per 100,000 died from mental health related causes. 71 of those women died by suicide and 43 in relation to drug or alcohol misuse. Alongside this, we examined the care of 23 women who had a previous history of postpartum psychosis or psychosis associated with a bipolar disorder. One of the main messages, I think, which is of direct relevance to a number of the talks you had earlier, thinking about screening, perhaps, is that actually the commonest diagnosis amongst the women who died was a recurrent depressive disorder. The vast majority of the women who died by suicide had a prior history of mental ill health. In relation to the last talk just before lunch, a quarter had a history of domestic violence or abuse. So these are a vulnerable population. What we're not now seeing are women who are dying after new onset puerperal psychosis. There was a big emphasis in the reports in the early 2000s in the UK about women who presented with new onset psychosis, and we're not seeing that group of women dying any longer. So I do feel we've made a difference, but we've clearly got a long way to go. When you look at the timing of the deaths by suicide, they're actually spread throughout that 1 year after women have given birth. And the most important message is that women clearly are dying by violent methods, which is very different to the pattern of suicide that you see amongst non-pregnant women and amongst and much more similar to the pattern of suicide that you see amongst men. So I'm just going to pick out these 5 key messages from our confidential inquiries. There are many more messages in the reports, but they're all online, so if anybody wants to have a look at them, please do. So this woman died by hanging 4 months after she gave birth. She had a previous history of depression, eating problems, and self-harm, but none of this history was passed on to maternity services. So maternity services were unaware of a return of her eating difficulties. In the postpartum period, she did disclose thoughts about ending her own and her children's lives, but this information wasn't shared amongst professionals, and she was seen by a range of different professionals, but her care wasn't well coordinated, so nobody responded to her worsening mental ill health. So if we're talking about screening, if you do one thing and one thing only, it's important that you ask women about their previous mental health history. And if you do know that a woman has a history of previous mental health problems, share that information with all of the relevant professionals involved in her care. Most of the women who died by suicide had been seen multiple times in pregnancy by multiple professionals, and nobody had joined together the pattern to work out that her mental health was deteriorating, and each consultation, each presentation was treated as a single event. We have identified a number of red flags, and one was evident in that previous woman who had expressed an intent to commit suicide using a violent method. This woman also died by hanging several months after the birth of her first child. She did report that her mood was low, but particularly she expressed very strong beliefs that her baby deserved a better mother than her, repeating these both to the health visitor and to the mental health team. She described those worsening suicidal thoughts of a violent nature, but most of the mental health staff that she expressed that to thought that they were just fleeting and transient. She was accepted for intensive home treatment, but she took her own life before that started. And these are the red flags that we have identified and are now communicating throughout all the teams caring for women during pregnancy and postpartum. So a recent significant change in mental state or new symptoms, new thoughts or acts of violent self-harm, and new and persistent expressions of incompetency as a mother or estrangement from the infant. Just alongside those red flags, always regard those new expressions of or acts of violent self-harm seriously, and think particularly if a mother doesn't appear detached from her infant but is expressing that she feels incompetent, that may be a reflection of significant psychotic thinking. We've also identified that our general mental health teams are very poorly aware of the specific concerns around perinatal mental illness. So this mother was unusual in that she had no prior history of mental health, and she presented to her GP with a low mood 6 months after delivery. Her primary care doctor treated her with antidepressants. 1 week before she died, she presented to the emergency department and she expressed those suicidal ideas. Her mother had to stop her, prevent her from harming herself violently earlier in the day. The consultant psychiatrist advised admission, but actually the general psychiatric team were very precious about their small number of beds, and they felt she could be managed at home, and she died by hanging shortly afterwards. The general team had not appreciated the speed with which perinatal mental illness can get much worse, and therefore hadn't appreciated how urgent the need to admit her was. So we now have identified and developed specific training for those general psychiatric teams, as well as continuing professional development to understand the distinctive features and risks of perinatal mental illness, particularly if they're providing emergency and out-of-hours care. A new finding that we've identified, in fact, not just in relation to maternal mental health, but in terms of maternal medical conditions as well, is the issue of de-prescribing. So this woman died by violent means in her 3rd trimester. She had a previous history of anxiety and depression and previous depression in a postnatal period. And she had been prescribed venlafaxine prior to the pregnancy, and it worked well. But it was stopped when she found she was pregnant. We're not entirely clear whether it was by the woman herself or by her doctor, but it was clear that she saw her doctor several times and actually specifically asked to restart her medication because it had been very effective for her. The doctor was clearly very reluctant to prescribe and placed responsibility for the decision entirely on the woman. And the doctor had documented throughout the notes an explanation of the risks of taking medication, but not the benefits. And the woman died a week later on the day she was due to undergo a mental health assessment. So we now recommend that decisions on continuing, stopping or changing medication should be made only after careful review of both the benefits and the risks of doing so to both mother and infant. We know that previous postpartum psychosis significantly increases your risk of a recurrence of psychosis in a future postpartum period. But we did identify, particularly when looking at the women who survived, that they didn't always receive advice on that risk or advice on ways that they could lessen that risk. And sometimes the risk was underestimated or misattributed. So this woman required admission for postpartum psychosis. Her diagnosis was delayed because it was attributed to personality factors. On recovery, she requested a discussion about her future risk, but she received no information on risk reduction strategies. This also happened again during a future pregnancy 3 years later, after which she unfortunately relapsed. However, we can see the effect of good care and the impact if following recovery, those discussions of risk and the consideration of re-referral for subsequent pregnancies is taken into account. This woman also developed postpartum psychosis requiring admission about 6 months after the birth of her first child. Although at that time, many of the messages that we've identified were seen, so her symptoms were under-recognised and her treatment was delayed, she did receive good inpatient care and a very good discussion of future risk and risk minimisation strategies at discharge. In her subsequent pregnancy, there was good communication. She had appropriate early referral, engagement with services. She had a late pregnancy placing plan, and she had prophylactic treatment and no acute relapse. When we look at the care of women who survive compared to women who died, the care is better amongst the women who survive, so we felt that only in about a quarter of women the care might have made a difference to their outcome, compared with half of women who died. But it is evident that we are far from perfect, even in our care for women who recover from their peripartum psychosis. So these are our core messages in terms of perinatal mental health. Forward planning works, and this applies across mental health and physical health problems. So before pregnancy, plan contraception. A number of the women who died had unplanned pregnancies. Plan the safest medication, so women know what to do if they find themselves pregnant. Don't stop medication in early or later pregnancy without consulting a specialist. Think about special medication considerations around the time of labour or birth, and in the case of peripartum mental illness, this may involve starting some prophylactic medication. And think about the changes that occur in the postpartum period and change medication accordingly. And at that point, think about contraception as well as planning for the next pregnancy. And remember those red flags. If you see a woman who is expressing thoughts of violent suicide, please take it seriously and think about referring her for a mental health assessment. Thank you.